I'm about to reveal something that might shock you about what's happening inside your body while you sleep. After years of treating patients with diabetes, after seeing the devastating complications that develop from uncontrolled blood sugar, I've learned something that most doctors never explain to their patients. Your blood sugar doesn't just sit there quietly while you're sleeping. It's moving, rising, spiking. And for millions of people over 60, those overnight spikes are silently destroying their bodies, damaging their organs, shortening their lives, and they have absolutely no idea it's happening. What I'm about to share will change everything you think you know about managing diabetes and blood sugar. Your doctor probably told you to check your blood sugar in the morning when you wake up and maybe before meals during the day. But what's happening between bedtime and morning during those 6 to 8 hours while you're asleep is often far more dangerous than anything happening during the day, and almost nobody is monitoring it. Almost nobody knows it's occurring. The damage is invisible until suddenly it's not. Until suddenly you're dealing with kidney failure or vision loss or neuropathy so severe you can barely walk. By the end of this video, you'll understand exactly why blood sugar spikes overnight, what mechanisms might be causing it in your specific case, and most importantly, what questions to ask your doctor and what monitoring strategies can help identify the problem. This isn't about self-treating or adjusting your own medications. This is about understanding the physiology so you can work effectively with your healthcare team. Stay with me because what you're about to learn could help protect your kidneys, your eyes, your nerves, and your life. Before we begin, a critical disclaimer. The information I'm sharing today is strictly for educational purposes and should not be considered medical advice. Dr. Sarah is not your personal physician and cannot provide individualized medical guidance through this video. Never stop, start, or change any diabetes medication without first consulting with your doctor. Never adjust insulin doses on your own as this can cause life-threatening hypoglycemia. Never ignore professional medical advice because of something you learned in this video. Every person's diabetes is unique, and what I discuss here may not apply to your specific circumstances. The monitoring strategies and physiological explanations I share are meant to help you have informed conversations with your healthcare provider, not to replace professional medical care. Always work closely with your endocrinologist or primary care physician to make decisions about your diabetes management. Let me tell you about Margaret. Margaret was 68 years old when she first came to see Dr. Sarah. She'd been living with type 2 diabetes for 12 years. 12 years of checking her blood sugar multiple times daily. 12 years of taking her prescribed medications faithfully. She was on metformin, 1,000 milligrams twice daily, and glipizide, a sulfonylurea medication, 5 milligrams once daily. She was doing everything her doctor told her to do. She attended all her appointments. She tried to eat carefully. She was compliant. Margaret was diligent about checking her blood sugar. Every single morning when she woke up, before she even got out of bed, she'd reach for her glucose meter sitting on the nightstand. She'd lance her finger, apply the blood to the test strip, wait for the reading. And every morning, the number staring back at her was devastating. 168, 174, 182, 186, sometimes even higher. Her fasting morning blood sugar, what doctors call fasting plasma glucose, was supposed to be under 130, according to the American Diabetes Association guidelines for people with diabetes, ideally under 100. Margaret's was consistently in the 160s, 170s, sometimes pushing close to 200 every single morning without exception. But here's what confused and frustrated her so deeply. She was extremely careful about what she ate for dinner. She'd measure her portions. She'd have a palm-sized portion of lean protein, grilled chicken breast or baked fish, a large serving of non-starchy vegetables, steamed broccoli or a salad, maybe a very small amount of brown rice, or half a small sweet potato. Nothing excessive, no dessert, no sweets, no nighttime snacking whatsoever. She'd finish dinner by 6:30 or 7 p.m. and wouldn't eat anything else, not a single bite, until breakfast the next morning. She'd check her blood sugar at bedtime around 10 p.m. before taking her evening dose of metformin, and the reading would be reasonable, acceptable, even 138, 142, 135, 148, not perfect, but under 150. Her endocrinologist had told her that anything under 150 at bedtime was acceptable, that she was doing fine. So Margaret would go to sleep thinking everything was under control. Her bedtime blood sugar was in an acceptable range. She hadn't eaten anything after dinner. She was taking her medications as prescribed. She was following the plan. There was absolutely no reason for her blood sugar to go up overnight. But every single morning, without fail, she'd wake up to find her blood sugar 30, 40, 50, sometimes even 60 points higher than it had been when she went to bed 8 hours earlier. She'd gone from 140 at bedtime to 185 in the morning while she was sleeping. while she was lying in bed doing absolutely nothing, while she wasn't eating, wasn't moving, wasn't doing anything at all? How could this possibly be happening? Where was this extra glucose coming from? She wasn't eating. She wasn't consuming anything. She was just sleeping. How could her blood sugar be rising so dramatically, so consistently every single night? Margaret asked her endocrinologist about this repeatedly over several years. At every 3-month follow-up appointment, she'd bring up the same concern. Doctor, I don't understand. My blood sugar at bedtime is okay, but every morning it's so high. I'm not eating anything overnight. What's happening? What am I doing wrong? Her doctor's response was essentially the same every time. Your diabetes is just progressing. Your blood sugar control is deteriorating. We need to add more medication. Let's increase your metformin to the maximum dose. Let's add another medication. Eventually, you may need to start insulin. But Margaret was already experiencing side effects from her current medications. The metformin, even at her current dose, gave her chronic digestive problems, bloating, cramping, unpredictable diarrhea that made leaving the house anxiety-inducing. She'd learned to stay near bathrooms. The glipizide sometimes made her feel shaky and dizzy around mid-afternoon when her blood sugar would drop lower than comfortable, causing mild hypoglycemic episodes that left her sweating and trembling. The idea of adding more medications, especially insulin, with its risk of severe hypoglycemia, terrified her. She had heard stories from other diabetics. She knew someone who'd passed out from low blood sugar while driving and crashed her car. She knew someone else who'd had a severe nighttime hypoglycemic episode, dropped into the 30s while sleeping, and his wife couldn't wake him up and had to call 911. Margaret was frightened. She felt like she was doing everything right, and still failing. She felt like her body was betraying her. Every single morning when she saw those elevated numbers on her glucose meter, she felt defeated, frustrated, angry, scared. She knew what those numbers meant for her future. She knew the trajectory she was on. She'd read extensively about diabetes complications. She understood diabetic retinopathy, how chronically elevated blood sugar damages the tiny capillaries in the retina, causing them to leak fluid and blood, leading to macular edema, retinal detachment, proliferative changes, and ultimately, blindness. Her maternal aunt had lost her vision completely from diabetic retinopathy in her early 70s. Margaret remembered visiting her aunt in the assisted living facility, watching her navigate the world in total darkness, completely dependent on staff for every basic need. That image haunted Margaret. She knew about diabetic neuropathy. She understood how persistent hyperglycemia damages the glomeruli, the filtering units in the kidneys, causing progressive loss of kidney function that eventually leads to end-stage renal disease requiring dialysis or transplant. 3 times per week for 4 hours at a time, hooked up to a machine that does the work your failed kidneys can no longer do. She had a close friend who'd been on hemodialysis for 3 years before dying from complications. She'd watched her friend's agonizing decline, the constant fatigue, the severe dietary restrictions, the vascular access problems, the infections, the suffering. Margaret didn't want that fate. She knew about diabetic neuropathy. She understood how hyperglycemia causes oxidative stress and accumulation of advanced glycation end products that damage peripheral nerves starting distally in the feet and gradually progressing proximally. The burning pain, the electric shock sensations, the numbness that prevents you from feeling injuries until they become infected, the autonomic dysfunction affecting your heart rate, digestion, blood pressure regulation, the diabetic foot ulcers that won't heal, becoming deeper and deeper until bone is exposed, and amputation is the only option. Her father had lost his right leg below the knee to diabetes when he was 72. She remembered him in the hospital after the surgery, looking down at where his leg should be, the profound grief and shock in his eyes. Margaret was terrified of that happening to her, and she knew these devastating complications didn't happen suddenly or overnight. They developed slowly, insidiously over years and years of inadequately controlled blood sugar. Every single day with blood sugar above target was another day of cumulative microvascular and macrovascular damage. Every morning she woke up to a fasting glucose of 170 or 180 was another morning of ongoing injury to her retinas, her kidneys, her peripheral nerves, her coronary arteries, her brain. She felt trapped. She felt helpless. She felt like no matter what she did, no matter how carefully she ate, no matter how compliant she was with her medications, her blood sugar was going to stay elevated. The damage was going to continue accumulating, and eventually she developed the same horrifying complications her father and aunt had suffered. It felt inevitable. It felt like she was watching a slow-motion train wreck and was powerless to stop it. When Margaret came to see Dr. Sarah, she was desperate for answers, desperate for hope, desperate for someone to actually explain what was happening instead of just telling her she needed more medication. "Why is my blood sugar going up overnight?" she asked me, and I could hear the frustration and fear in her voice. "I'm not eating anything. I'm not doing anything. I go to bed at 140 and wake up at 185. Where is that extra glucose coming from? What am I doing wrong?" Please help me understand. I looked at her blood sugar logs. Months and months of readings meticulously documented. I saw the pattern immediately. Bedtime readings in the 130s and 140s, morning readings in the 170s and 180s, consistent elevation overnight, and I knew exactly what was happening. Margaret, Dr. Sarah said, "You're not doing anything wrong. Your blood sugar is rising overnight because of specific physiological processes happening in your body while you sleep, but nobody's explained this to you properly. And more importantly, nobody's given you a framework for understanding it or working with your doctor to address it effectively." Margaret's eyes filled with tears. "You mean it's not my fault? There's actually an explanation for this." "Yes," Dr. Sarah told her. "But you need to understand the mechanisms first, because there are actually several different reasons blood sugar can rise overnight. And the approach depends on which mechanism is affecting you. You can't fix what you don't understand." Over the next 6 months, working closely with her endocrinologist, we systematically identified Margaret's specific causes, and her doctor adjusted her treatment accordingly. Her morning fasting blood sugar dropped from averaging 178 down to averaging 132. Still not perfect, but a dramatic 46-point improvement. She felt hopeful for the first time in years. She felt like she finally understood her diabetes instead of being a passive victim of it. But Dr. Sarah is not going to tell you what specific changes her doctor made yet. I'm not going to tell you the solution yet, because you need to understand the underlying physiology first. You need to understand why overnight blood sugar elevation happens at all, because there are actually multiple distinct mechanisms, and most people with this problem have more than one operating simultaneously. Comment below if you've experienced this frustrating phenomenon. If you've gone to bed with acceptable blood sugar and woken up with it significantly higher, type overnight spike if this has happened to you. I want to see how many people are dealing with this invisible problem that so profoundly impacts diabetes control. So why does blood sugar rise overnight when you're not eating anything? Where does that extra glucose come from? Let me explain the physiological mechanisms, because understanding these is absolutely essential to having productive conversations with your doctor about how to address the problem. The first and most common mechanism is called the dawn phenomenon, also sometimes called the dawn effect. This affects the majority of people with diabetes to varying degrees. The dawn phenomenon is driven by normal circadian hormone rhythms that occur in every human being, diabetic or not, every single night. Here's the physiology. In the early morning hours, typically between 4 a.m. and 8 a.m., your body begins its natural wake-up process even before you're consciously awake. Your hypothalamus signals your pituitary gland, which signals your adrenal glands. Your adrenal glands begin secreting higher levels of cortisol. Cortisol is your primary stress hormone, but it's also your wake-up hormone. Cortisol follows a distinct circadian rhythm. Levels are lowest around midnight to 2 a.m., then begin rising sharply in the pre-dawn hours, typically peaking around 7 to 8 a.m. This cortisol surge helps you wake up alert and energized, but cortisol has metabolic effects beyond wakefulness. Cortisol is a counter-regulatory hormone. It opposes the action of insulin. Cortisol signals your liver to break down stored glycogen through glycogenolysis and convert it into glucose. It signals your liver to perform gluconeogenesis, synthesizing new glucose from amino acids, lactate, and glycerol. Cortisol is telling your liver, "We're about to wake up. We need energy. Release glucose into the bloodstream to fuel the body for the day ahead." In addition to cortisol, your body releases other counter-regulatory hormones during these pre-dawn hours. Growth hormone levels peak during deep sleep earlier in the night, but growth hormone effects on glucose metabolism persist into the morning hours. Growth hormone promotes lipolysis and reduces glucose uptake by peripheral tissues. Your sympathetic nervous system activity increases as you approach waking with rising levels of catecholamines like epinephrine and norepinephrine. These also promote hepatic glucose output and reduce insulin sensitivity. In a person without diabetes, with a normally functioning pancreas and normal insulin sensitivity, this early morning hepatic glucose release is perfectly matched by appropriate insulin secretion. The beta cells in the pancreas sense the rising glucose and secrete precisely the right amount of insulin to allow that glucose to enter muscle cells, adipocytes, and other peripheral tissues where it's needed. Blood glucose remains stable even though the liver is actively producing and releasing glucose. Everything stays in balance. But in a person with type 2 diabetes who has insulin resistance and impaired beta cell function, or a person with type 1 diabetes who produces insufficient insulin, this delicate balance is disrupted. Your liver releases glucose into your bloodstream in response to the cortisol surge and other counter-regulatory hormones. But your pancreas either can't produce enough insulin to match this glucose load, or your peripheral tissues are insulin resistant and don't respond properly to whatever insulin is present. That glucose accumulates in your bloodstream. It can't enter cells efficiently. Blood glucose concentration rises, sometimes dramatically. This is the dawn phenomenon. Your blood sugar rises in the early morning hours, typically between 4 a.m. and 8 a.m., driven by normal circadian hormone rhythms that your diabetic metabolism cannot properly compensate for. You might go to bed with blood glucose at 140. At 2 a.m., it might still be around 140 or even slightly lower, but between 4 a.m. and 7 a.m., your liver is actively dumping glucose into your bloodstream and your body can't handle it appropriately. By the time you wake up at 7 a.m. and check your blood sugar, it's 180 or 190. The dawn phenomenon can raise blood glucose by anywhere from 20 to 100 points during those early morning hours, depending on the severity of your insulin resistance, your degree of beta cell dysfunction, the intensity of your counterregulatory hormone surge, and various other individual factors, and there's nothing you consciously did to cause it. You didn't eat anything. You didn't make any behavioral errors. It's your body's normal hormonal rhythms interacting with your diabetic pathophysiology to create this elevation. But here's what many people don't realize. The dawn phenomenon isn't just affecting your single morning fasting glucose reading, it's affecting your entire day's glycemic control. When you start your day with blood glucose at 180 instead of 110, everything downstream is elevated too. Your post-meal spike is higher because you started higher. Your pre-lunch reading is higher. Your whole day's glucose curve is shifted upward because you began the day elevated. This means more time spent hyperglycemic, more glycemic variability, more cumulative exposure to elevated glucose, more damage accumulating over time. The second mechanism, which is significantly less common than the dawn phenomenon, but extremely important to recognize, is called the Somogyi Effect, named after Dr. Michael Somogyi, who first described it in the 1930s. This is also called rebound hyperglycemia. The Somogyi effect has completely different pathophysiology and requires a completely opposite therapeutic approach from the dawn phenomenon. Getting this wrong can be dangerous. Here's what happens with the Somogyi effect. Your blood glucose drops too low during the night, typically between midnight and 3 a.m., often into the hypoglycemic range below 70 millimoles per deciliter, sometimes even lower into the 50s or 40s. This nocturnal hypoglycemia can occur for various reasons. Perhaps your evening diabetes medication dose is too high. Perhaps you took your usual medication dose, but ate less dinner than usual. Perhaps you exercised in the evening, and your muscles are still pulling glucose from your bloodstream hours later, creating delayed hypoglycemia. Perhaps you consumed alcohol with dinner, which impairs hepatic gluconeogenesis and can cause delayed hypoglycemia. When your blood glucose drops into the hypoglycemic range, your body perceives this as a life-threatening emergency. And rightly so, severe hypoglycemia is acutely dangerous. Your brain requires a constant supply of glucose to function. Unlike other tissues that can use alternative fuels, your brain is almost entirely dependent on glucose. If blood glucose drops too low, you can lose consciousness, have seizures, suffer permanent brain damage, or die. Your body is programmed to prevent this catastrophe at all costs. So, when blood glucose drops too low, your body initiates a powerful counterregulatory response. Your adrenal glands rapidly release epinephrine, also called adrenaline. This is your fight or flight hormone. Epinephrine causes multiple rapid physiological changes. Your heart rate increases. Your blood pressure rises. You might sweat. You might feel shaky or anxious. But metabolically, epinephrine does something critical. It signals your liver to immediately release glucose through glycogenolysis, the breakdown of stored glycogen. Your adrenal glands also release cortisol in response to hypoglycemia. The alpha cells in your pancreas release glucagon, a hormone whose primary function is to raise blood glucose by stimulating hepatic glucose output. Growth hormone secretion increases. All of these counterregulatory hormones work together to mobilize glucose and raise your blood glucose back up to safe levels. The problem is that this counterregulatory response, especially in someone with diabetes who may have impaired glucose sensing or dysregulated hormone responses from years of diabetes, often overshoots dramatically. The goal is to bring blood glucose back up to normal, maybe 90 or 100, but the response is so aggressive that blood glucose doesn't just return to normal, it shoots way up, often into the 150s, 160s, 170s, or even higher. This is the rebound hyperglycemia. And here's the truly insidious aspect of the Somogyi effect. You sleep through all of this. Most people don't wake up when their blood glucose drops to 60 at 2 a.m. They don't feel the adrenaline surge. They don't sense the rebound. They sleep through the entire event. They wake up at 7 a.m., check their blood glucose, and it's 185. They think, my blood sugar is high again, my diabetes is getting worse. But what actually happened is that their blood glucose went dangerously low overnight. Their body launched a massive counterregulatory response, and they're seeing the aftermath of that hormonal rebound. The Somogyi effect is particularly problematic because it's often iatrogenic, meaning caused by medical treatment. Your doctor sees your elevated morning fasting glucose readings and thinks, we need to control this better. Let's increase the evening medication dose. So your bedtime insulin gets increased, or your evening sulfonylurea dose gets raised. But this higher medication dose makes you more likely to experience nocturnal hypoglycemia. The hypoglycemia triggers an even bigger counter-regulatory rebound. Your morning glucose readings paradoxically get worse instead of better. The doctor sees the worsening morning readings and increases medications further. The cycle continues, potentially leading to severe and dangerous hypoglycemia. This is why it's absolutely critical to distinguish between the dawn phenomenon and the Somogyi effect. They present similarly with elevated morning fasting glucose, but the underlying mechanisms are completely opposite, and the therapeutic approaches are opposite as well. Treating the dawn phenomenon often involves adding or adjusting medication to provide better overnight glucose control, but treating the Somogyi effect requires reducing medication to prevent the nocturnal hypoglycemia that's triggering the rebound. Getting this wrong can be harmful or even dangerous.